Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 36 of the OBGYN podcast. This is the Journal Club for July 2018, and here with me today are two new guests that I'm very excited to have on the show. They are both minimally invasive gynecologic surgeons at Stony Brook. The first is Dr. Jen Blaber.
Hi, everyone. Thank you, Joe, for having me.
Great to have you here. And the second one is Dr. Julie Lian.
Hi, everyone. I'm excited to be on this episode.
So thank you so much for being here today. I think we're going to have a very interesting discussion about this paper, and I'm very interested to hear what you both have to say about it. So obviously I chose a paper that is about minimally invasive surgery, because that's why you're both here. And this paper is Laparoscopic versus Transvaginal Cuff Closure After Total Laparoscopic Hysterectomy, a randomized trial by the Italian Society of Gynecologic Endoscopy. Mouthful. It is by Stefano and Uccella. They're all from Italy, obviously. And it was published in the Gray Journal in May 2018. So this paper is really the product of the rise in total laparoscopic hysterectomy over the last decade or so. And as anyone who does that procedure will tell you, there is definitely a learning curve to suturing laparoscopically. It is not something that is, I think, just easy to pick up. You have to do it a few times to get good at it. And as this paper quotes, there was some previous literature suggesting that closing the cuff vaginally was superior as far as cuff dehiscence. But all of that literature was either small or retrospective, and so what this paper really set out to do was take that to the next step, next level, and do a randomized controlled trial. So before we get into the actual paper, I'm interested to hear what you guys do in your practice. I know both of you do a lot of laparoscopic hysterectomies.
So in my practice, I solely close the cuff laparoscopically. And at this point, I am using a barbed suture to do that.
Okay, and we're definitely going to get into that later. That's one of the things they talk about. How about you, Dr. Lian?
Since Dr. Blaber and I trained at the same institution by the same faculty, I similarly also predominantly close the cuff laparoscopically with barbed suture. However, on the rare occasion that I have to morcellate vaginally for whatever reason, in that case, I will close the cuff vaginally for those instances.
Okay. I mean, that's basically where I'm at, too. The three of us trained kind of over the last 10 years, we've all trained, and we all kind of trained from the same person, if you will. And so we all basically do the same thing. I also do a lot of TVHs, and so I do close the vagina vaginally that way. But, laparoscopically, I'm with you guys. I usually do it with a barbed suture and not intracorporeal knot tying, which is what they do here. But in any case, so they describe why they want to do this paper. They want to go back and do a real randomized controlled trial to see once and for all what the correct way to close the cuff is. Whether they did that or not, we'll get into. But what they did is they wanted to look at the absolute rate of cuff dehiscence and also other outcomes associated with the cuff, and we'll get into those in a little bit. And so that was kind of their primary, secondary outcomes. The first thing I wanted to talk about with both of you is kind of the ethics of doing a randomized controlled trial when you're randomizing the woman to having a different intervention like this, closing one way or the other. Do you think there's any issues with that kind of study, with this kind of cuff closure?
I personally don't, not with this study, because it seems like the surgeons involved in the hospitals seem to be all trained to close laparoscopically and vaginally. So because it seemed like the surgeons are good in both modalities, I don't think there's any ethical issues.
Fair enough. I think it's fine, obviously, as long as there's informed consent for the patients. They're going to quote some numbers later. They're roughly equivalent as far as rates of cuff complications. It's not like one's 10% and one's 1%, and actually they're going to get into that later as well. But I thought it was something a little interesting. So what they did is they did 8 different institutions who are all doing these surgeries, and they randomized people to who are getting a laparoscopic hysterectomy to either do a laparoscopic closure or a transvaginal closure. Either way, they were doing a running closure with 0 vicryl. They were not using barbed. And they were obviously not doing interrupted. So that was their kind of thing. Now, I had a few questions about this 8 different sites that were doing this. Who were the surgeons? How experienced were they? One of the things they don't really mention, they do mention that these sites have a high referral centers, so they were doing greater than 500 gynecologic interventions, whatever that means, per year. But individual surgeons doesn't really tell me how comfortable those surgeons were. So if you took one of us, who do mostly laparoscopic closure of the cuff, and said, I want you to do a vaginal closure of the cuff, well, that might be inferior to us doing it laparoscopically, and vice versa. If someone's doing a lot of vaginal hysterectomies and now you're going to ask them to do, on their laparoscopic cases, to close it vaginally, they'll be comfortable with that. And we didn't really get any information about that, which is one of my major concerns.
Yeah, no, they didn't really get into that at all.
Yeah, we also have no information about the training of the surgeons involved, as far as whether or not any of them were subspecialists in urogynecology or minimally invasive surgeons, and that could impact, their comfort level with a vaginal closure.
Yeah. I mean, in fairness, I don't really know what the training setup in Italy is as far as that, and so that
True.
may not even be a thing. But that underlying, how many of those cases do they do on a regular basis is basically what you're still getting at. And I would have liked to have seen that. But maybe they either didn't have the information or would have made it overly long. As far as the surgery itself, now I'm actually impressed that they were able to get all these surgeons to do the same surgery the same way. If we tried to do that at Stony Brook, we would only last about 2 days, and that would be it. But they used, like I said, zero Vicrotic the cuff. Interestingly, they used monopolar to incise the vag cuff, which, as listeners may know, we know that the rate of cuff dehiscence with a monopolar technique, as opposed to something like a harmonic or using ultrasound technology, does seem to be associated with a higher rate of dehiscence. So there is that. They didn't really mention that in their paper, but it's there. And then they use intracorporeal knot tying, and I don't really care one way or the other. I think they're both intracorporeal, extracorporeal, probably both fine. I'm just impressed that they were all doing intracorporeal knot tying, because that actually, whenever I do that, there ends up being a lot of swearing in the operating room.
I think what stuck out for me was that when I read they were doing intracorporeal knot tying, it did make me think that the ability of the surgeons was such that they were very comfortable with that modality, and so they must be expert level surgeons, laparoscopically at least. I was also impressed, as what you said before, is that the number of protocol violations was impressively small, that they actually got the number of surgeons participating to adhere to the protocol as often as they did was really nice.
Yeah, although, to be fair, they don't actually tell us how many surgeons were involved.
True, could be only 8 if there's 8 institutions.
Could be. I mean, there's a lot of names on here. I don't know, maybe there's got to be at least a dozen names on the papers, so I'm assuming a lot of those are the surgeons who were involved, but they don't tell us, again, which is one of my complaints. So then getting into the rest of their procedure, their postoperative follow-up now, so the beginning for the patients was a blinded randomization. Obviously, the surgeons weren't blinded because they had to do the surgery. But the postoperative follow-up was done by other people, and that was blinded. So the people who were doing the follow-up did not know what kind of closure they had, which I thought was a nice touch. It was a good way of keeping the bias down a little bit. And how they evaluated things. So they looked at the cuff, that's fine. They noted any dehiscence, and they included any dehiscence as any separation of the vaginal mucosa. It's fine. Complete dehiscence would be bowel coming through. Partial would be no bowel. Then when we get into some of their secondary outcomes, this is where I get a little fuzzy. So in the hematoma, they said any blood collection at the vag cuff or detected by ultrasound, which is fine, but then who got an ultrasound? Did everyone get an ultrasound? Or only if they had bleeding?
That's a very good question.
Right, and are those hematomas also clinically relevant? If it's really small, does that matter?
Right. Now, we don't actually know because no one really does routine ultrasounds on women after hysterectomy, at least not that I've seen, although maybe that would be a good study to do. But so we don't really know how big is big or how big is clinically significant. And like I said, we also don't know who got an ultrasound. So the fact that, and we'll get into the results how many they found, but that may not be all of them that there were, just the ones that they detected by doing ultrasound. So that was a little fuzzy for me.
Another definition that I found fuzzy was the definition for intraoperative complications being any deviation from the ideal intraoperative course. And I think that's a very vague, vague definition.
Yeah, I thought that was cute too. I'm not really sure what that meant. And I want listeners to realize that when we are making our quibbles about this stuff, it's not to say that this was not a well-done study. In fact, at the end, I'm going to probably say that it is a well-done study, but that we're still going to nitpick about the little things because that's what makes a journal club fun. So I think they did an overall decent job, but these are just some little things that I think they could have done differently that would have enhanced our understanding of what happened. For infection, which was another one that they looked at, they basically said any infection that was deemed to be involving the cuff, and you guys can't see me, but I'm using air quotes when I say deemed to be including the vaginal cuff, because again, we don't really know what that means. One of the things I found interesting about their postoperative course is that they told the women to avoid any vaginal intercourse for at least 2 months. And at least in my practice, I say a month. I don't know. What do you guys say?
I will say that in my training, I did anywhere between a month and 6 weeks. And now as an attending, I'm finding myself going closer to that 2-month mark. And in fact, sometimes even going past it. And I don't know if that's a function of me using a barbed suture that has a longer time to absorption. And so I'm still finding a greater suture load than I'd like at the vaginal cuff at the time of the 6-week postoperative visit. And so I think I'm, in a conservative way, extending the pelvic rest further than I did in my training because that suture volume is still there. Okay.
How about you, Dr. Lian?
I would usually tell patients 6 to 8 weeks. And again, it depends on at their exam at 6 weeks if I still see the barbed suture as well.
Okay. Well, I guess I'm the odd one out here. So I guess maybe I'm the one who changed my practice. And I'm okay. So, we do journal clubs to learn.
But again, it's I don't know how relevant it is to see the suture at the 6-week mark. Does that mean that the integrity is still weakened? Right. I'm not sure.
Yeah, it really shouldn't. They use Vicryl here. Vicryl, by 6 weeks, it's really lose 50% of its tensile strength. By 12 weeks, it should be mostly absorbed, and that's when they're doing their follow-up at 3 months. What we use is more like a PDS type material, and that's probably going to last a lot longer. So I wouldn't think that it would be absorbed even at 2 months. That being said, it is barbed, so it might be good contraception right there. But, who knows? So maybe I should go to 2 months. I'll have to think about that.
I would say most of my patients are not complaining.
Fair enough. The sample size calculation is interesting, something to talk about, because it's actually going to go into how their study was concluded. So they did a nice power analysis. They used the previous literature to say that the rate of cuff dehiscence with TLH was 1%, and with a laparoscopic closure, and then with a transvaginal closure was 0.2%. Again, this is all done on retrospective data, as they mentioned, or a small case series, which is limited right there. And I will say that where I have seen randomized controlled trials and even my own trials break down is when we assume a certain level of incidence of whatever we're looking at, and then our incidence is usually way higher or way lower, and then we either we collected too many patients really, or we didn't have enough, and usually we end up with not enough. And that is one of the issues with doing these randomized controlled trials with limited previous literature, is that you can end up with wildly different sample sizes. And that's going to happen to them here as well. So they calculated they would need 1,258 patients in each arm, which again, so they're going to calculate 2,700 women in this study. That is huge.
It's a lot of patients, yeah.
Right. I would have to look to see how many hysterectomies that we do at Stony Brook in a given year as a whole institution, and it's got to be in the 100 to 200 range. If it's any higher than that, I would be impressed. What do you think, Dr. Blaber?
I think it's probably around 500.
500 a year?
Including the oncology cases.
Okay, fair enough. Including I was thinking benign. So absolutely, including the oncology, that's probably true. So again, even if we did this, it would take us 5 years to do this, which is, again, obviously why they chose 8 different locations, where, again, you are sacrificing some of your control over the trial for increased volume. Now, they had predetermined to do a interim analysis at 50% enrollment to make sure that they were not... there wasn't one was so much better than the other that they were actually harming patients by doing it, and this is standard procedure, and it was nice they did it. They determined that they would stop the trial if one of the two groups was better with a alpha of less than or equal to 0.01. So usually we use 0.05. So this is very significant at 0.01 for either the primary or secondary outcomes. And they also looked at a couple of other endpoints I'm not going to get into. So they did that, and they actually did stop the trial. So now, before I get into the results and the discussion, anything that jumped out at you that I didn't mention from the materials and methods?
I guess my question was, they did say in their exclusion criteria, they excluded any patients with malignancy preoperatively. But then they do mention that, I guess this is discussed afterwards, they had 6 patients or so who had diagnosed malignancy after the surgery, and they still included those patients in the outcome. Right,
so they did an intention to treat analysis.
Oh, right.
And so they kept all the women in regardless of whether they would have been excluded. We could argue about what the pros and cons of doing intention to treat, but that's what they did.
Right.
So, they actually had enough numbers where if they had excluded those women, it wouldn't have really mattered. But they chose to include them, so that's fine. They're probably not... cancer is going to have obviously an increased risk of dehiscence, but those numbers were small enough, I don't think it's going to affect their overall outcome.
Right, that's true.
All right, so Dr. Blaber did allude to a little bit earlier. So they ended up enrolling 1,408 women, 703 in the transvaginal closure, 705 in the laparoscopic closure. They lost a total of 13 patients to follow-up, kind of evenly distributed. Then they had some protocol violations. In the transvaginal... Actually, let me start with the laparoscopic closure. They had 7 women who had a barb suture used, and so those were excluded. And they had 31 who had an interrupted suture technique, and they were excluded. So they lost about 38 there, which, fair, like I said, you're doing a large volume over 8 different hospitals. I'm surprised it wasn't higher than that. In the transvaginal closure, they had 1 that was lost for interrupted stitches, 3 who actually ended up with laparoscopic closure because they thought the vagina was too narrow to get in there to close. And then they had 3 who used barb suture. That was actually interesting to me because I have never tried to use a barb suture vaginally, so I thought that was interesting. But in any case, they ended up with 688 in the transvaginal closure and 662 in the laparoscopic closure. Demographics-wise, they were essentially the same as far as age, BMI, obesity, parity, indication for surgery, previous surgery, diabetes, smoking, steroid use, postmenopausal status, or if they were sexually active. So there really was no difference across the board, which is good. It means the randomization was good. Mm-hmm. I don't really have anything else to say about that. Then into their complications, this is where things get a little interesting. So they found their overall postoperative complications were higher in the vaginal hysterectomy, the vaginal closure group, which again, so whenever you have this kind of amalgamation of complications, you put them all together into a postoperative complication group, and then you list all the other complications, and it makes kind of a meaningless category, so I'm not really sure why they included it, maybe just to irritate me. Then they looked at any cuff complication, and again, that was higher in the transvaginal closure group, but all of that came from essentially vaginal dehiscence, cuff hematoma, postoperative vaginal bleeding, and infection. So as far as dehiscence, which was their primary outcome, they did note that there was a 1% dehiscence rate in the laparoscopic closure, which was consistent with previous literature. However, the vaginal dehiscence rate was much, much higher than previous literature. It was 2.7%. And remember that in their sample size calculation, they had a 0.2%. So it was a tenfold increase over previous literature, which is huge. And we're going to end up, I think, spending a lot of our discussion of their discussion talking about that. Like I said, they also did note a much higher rate of cuff hematoma, 1% in the laparoscopic group, 2.9% in the vaginal group, and similar findings in postoperative vaginal bleeding, although I'm not really sure what postoperative vaginal bleeding means as opposed to the hematoma, but it was 2.7% in the laparoscopic group and 4.9% in the vaginal bleeding. Same thing, the infection. That was actually a much higher rate of infection in the transvaginal group, 4.3%, which is, to me, kind of huge, and 0.9% in the laparoscopic group. So I'll stop there, and I'll ask for your thoughts because I just read off a lot of numbers.
I mean, I think these results are very surprising to me, especially given, and as the authors discussed in the introduction, all the previous studies, while they were all retrospective, they were large number of patients, including these retrospective studies, including their own meta-analysis that they reference. And all those studies say that reported that the dehiscence risk was increased in laparoscopic closure versus vaginal closure. For me to see these results was very surprising.
Yeah, especially since the laparoscopic was kind of like dead on for the literature, that the vaginal was so different. It's crazy to me.
I think it calls into question the expertise of the surgeons again. Right. What are these surgeons used to doing? Are these your laparoscopic surgeons who you're asking to close vaginally? Because if you ask Dr. Lian and I to close vaginally, perhaps you'd come up with the same numbers.
Right. So I think what would have been interesting, and we're stealing from the discussion here, but that's all right. I think would have been interesting to say, prior to this start of the study, what was the normal routine for these surgeons? What percentage of cases did they close vaginally versus laparoscopic? Because I think that would at least told us what their normal was.
Exactly. And then some of the other issues I have with some of the other numbers you mentioned, vaginal cuff hematoma, as we alluded to before, we're not usually looking for that. So, how were all the patients getting transvaginal ultrasounds or abdominal ultrasounds to look for this, and why? What's the clinical significance of that, really, if they're very small hematomas? The next one would be postoperative vaginal bleeding. I counsel my patients that some amount of postoperative vaginal bleeding is acceptable and the norm. And the way they defined postoperative vaginal bleeding was any subjective bleeding, which could be a little bit of spotting here and there. And I think that's very normal as the cuff closes.
Right. I mean, the fact that it was only 5% or 3% actually seems a little low to me.
Exactly.
Yeah. I would say most of the women that I do hysterectomies on will report some spotting at some point.
Right.
Maybe hopefully not a lot, but they will report it. So I agree with you on that. And, I have to just think from a clinical point of view that the only people who were getting ultrasounds, unless they did it universally, which they did not say, were the people who came with vaginal bleeding. Because otherwise, or maybe pain. So I don't know. That whole part of this seems unnecessary to me, and they could have cut it out of the paper, and it would have been just as good, maybe better, because then I wouldn't spend time talking about it. So then they did so that was their primary outcome. Primary outcome was these complications, and they stopped the study early because they found that the vaginal closure was so much worse than laparoscopic closure. Fine. I agree with all that. Why was it worse? That's what we'll get into some more. But certainly I agree that they should not do it vaginally. They should do it laparoscopically because they have better outcomes. So then they looked at what risk factors were associated with cuff dehiscence. And they did this nicely. They did a univariate analysis to see what was significant first. And then they took those and put them into a multivariate analysis to see what was independent and what was dependent. And so that was nice. Basically what they found was that smoking and transvaginal closure were associated with more dehiscence independently, and that postmenopausal status was better. And that postmenopausal was actually similar to previous findings. I wasn't actually aware of that, so it's interesting to me, and we're going to come back to that at the end when we talk about their discussion. But that was new to me, so I thought that was interesting. And then this is where I'm going to nitpick a little bit, because these are the things that drive me crazy in a paper. I talked about it in the last paper, I think with Dr. Ballas. But so when they talk about table 4, they use this line. There was a tendency toward a significant association between smoking habit and any cuff complication. All right. So it's either significant or it is not significant. You cannot have a tendency toward a significant association. That drives me crazy. The last paper, it was like a trend to significance. I was like, stop it. It's either significant or it's not significant. And to go along with that, they also say, and I believe it's for age. I'm trying to see if I can find the exact quote. But they basically say that age is a significant factor with a p-value of 0.05. However, traditionally, and in their paper, they define significance as less than 0.05, not less than or equal to. So that is not significant. It's close, but it's actually not significant. So you got to choose what your cutoffs are, and then you got to stick by them. If you want to choose 0.06, you can choose. It's an arbitrary number anyway. You can choose what you like, but traditionally it's less than 0.05. So those are my nitpicks that drive me crazy. One thing I will say that I really kind of liked was figure 3 and 4, which where they had the Venn diagrams of dehiscence, hematoma, and infection to show which one had all three or two, so you could see about the hematoma and infection. Because one of the thoughts when I was reading it was, I wonder if all these infections have to do with all these hematomas, right? Because blood is there, it's a good culture medium, and it, so this kind of answered that question. Where I think about half of the hematomas in the transvaginal suture had infection, and impressively 0 of the hematomas in the laparoscopic closure had it. And maybe that is just because the way we're closing. Maybe there's less interaction between the vagina and the peritoneum that way. I'm not really sure, but I did find that striking that there were so few infections with hematomas in the laparoscopic group. So I'll stop there again after going through the rest of the results and to see if you guys have any thoughts on that.
To me, it made sense at least that there was less infection overall in the laparoscopic group.
Why is that?
I feel like there's less contamination of the field by staying in the belly than going to the vagina.
I mean, I think I agree with you. When you are in the vagina, it's almost like doing a cervical exam in labor, right? You are pushing with the contents of the vagina into the uterus by doing an exam. It's just a physical presence. Whereas in a laparoscopic, you are not doing that. You are pushing the other direction if you're doing anything, especially with the air escaping from the peritoneum into the vagina. So I would tend to agree with you. I think that's probably what it is. Now, I don't know, Dr. Lian, do you have any statements on this stuff?
I was also very shocked by or surprised by their finding that postmenopausal status was a protective factor. And I was not aware of the previous study that they referenced, because the older studies have all suggested that postmenopausal status and also pelvic organ prolapse increased the risk of dehiscence. So.
Right.
That was very interesting to me.
I mean, you would think with vaginal atrophy, less estrogenation, that you would have increased rate of dehiscence. That was kind of the intuitive thing that I thought.
Right.
In their discussion, they thought that the postmenopausal bleeding had to do with less sexual activity, that women who are postmenopausal have less intercourse. But they told other women not to have intercourse anyway.
Yeah.
So I wasn't really sure about that. And then, if they were going to bring that up, then I would have liked to have seen the breakdown in the postmenopausal women, the ones who were sexually active or not, because they had that information, but they didn't show it to us.
Right.
So I thought that was,
And actually, 80% of patients in both groups were sexually active, so it's a high number.
Right. But they don't tell us, they don't break it down by menopausal status.
I think the comment about sexual activity in postmenopausal women was totally out of line, because they counseled their patients specifically not to have sex in the postoperative period. And so I think that it shouldn't matter at all.
Right. So this is one of the things, when I'm writing a paper or when I am reviewing someone else's paper, is you really shouldn't bring up new things in your discussion. Everything in your discussion should have been foreshadowed earlier in the paper. And it's not like the discussion is coming at you like from the end. Like, that what you've already put in the paper when you write the discussion. Usually you don't write it as the first thing. So if they knew they were going to include that line, then they should have put more information somewhere else to allude to that. And if they couldn't do that, I agree they should have taken that line out. It didn't really make sense to me. So let's get into their discussion and see what they thought about this. They kind of say what we said a little bit, and what I was thinking is that if you go back 10 years, and a lot of the data that they quote as previous literature is not that recent. So if you go back 5-10 years, what you're dealing with is the learning curve for a lot of people for laparoscopy. Now, the man who taught me, and by extension taught both of you through other people, he's been doing it since the early 90s, right, and the mid 80s. So he was kind of at the front of the curve. But most of the people who learned how to do this in the last 20 years, right? It is a relatively new thing to do. And really, I'm talking 20 years in urban centers. If you go out further out of academic centers, it was more recent than that. So the learning curve here, I think, is what they were talking about, is as we've gotten better and better and better at laparoscopy, our dehiscence rate is going down because we learned things like, okay, when you're zoomed in laparoscopically, you think you're taking a big bite, but you're not taking a big bite, right? So we've all learned that you need to take a bigger bite than you think that you need to. And we don't even think that anymore. Now we just know what the appropriate bite is, right? But when you're first starting, that's what you're always told. No, take a bigger bite than that. It looks like a big bite, but it's not. That you can include the posterior peritoneum better when you're doing your closure. Now, they don't know that any of these things actually make it better, but they kind of make sense that they would, right? And so as we've gotten better at it, our distance rate for that is going down. And then maybe conversely, as we're doing more and more and more laparoscopy, we're doing less and less vaginal surgery, which is true, at least in the United States is true. And so it makes sense that our vaginal complication rate is going to go up just because we're not doing it as much. And so you're kind of seeing these two ships passing as we're having a change in practice. And that's really where they hang their hat. And I think I kind of agree with them. What do you guys think?
I definitely agree with them. I mentioned before that I think it has a lot to do with the volume of cases being done solely laparoscopically, and the vaginal modality falling by the wayside for a lot of these surgeons.
And I agree. There's definitely a learning curve to suturing laparoscopically, and it is definitely more skill involved, and getting a good bite is one of the keys. So I do think that potentially the difference in data could be the difference in technique and skill level.
I do like their explanation that the laparoscopic approach allows you to control the posterior peritoneum and incorporate it into your closure more completely, and that could be a reason why hematomas were less from the laparoscopic approach, and therefore dehiscence is less. That just all felt warm and fuzzy for me.
Fair. I mean, I will certainly say, as the one of the three of us who does more vaginal surgery, that it is very difficult to include the peritoneum very well in your entire closure. And a lot of people will actually include the posterior peritoneum into the vag cuff as soon as they enter to control bleeding. But certainly I have seen more vag cuff hematomas in vaginal hysterectomies than in my laparoscopic. So I'm not really surprised by that either. I do think you probably get a better closure in some senses laparoscopically. So then they do talk about a couple other things. They go into that postmenopausal stuff, which I think we beat to death, so we don't need to do that. And then they talk about, and this is the last thing where going back to the postmenopausal and how you shouldn't talk about things you haven't talked about before, they say, as a one little liner, that there was no difference by site. Okay, fine, but that needed to be in the results.
Well, that goes back to the point about not knowing a lot about these surgeons and their normal practice, and what each person was doing.
Yeah, and we just, they may know, but they didn't tell us.
Right.
And again, if they wanted to pull a fast one on us, they may have wanted to exclude that line, because then it just made me think about it more. So the actual line is, of interest, our data show no significant impact of the participating center on the risk of cuff dehiscence, but yet they don't break that out for us.
Right.
They have other tables, which I don't think we need, like, say, table figure 2, which I think is not necessary at all because we have the same information in table 2. So could have gotten rid of that one and given us another table about sites.
No, I mean, they do allude to that their surgeons are higher skilled because the one line says the expertise of the surgeons at the participating centers makes it highly unlikely that they performed poor techniques. So they allude to it, but I definitely would have liked to see what their experience, educational levels are.
Unfortunately, although the review for this was most likely anonymous, the people who participated in the study and whose name are on the paper is not anonymous. And so I'm not surprised they made a line like that because they don't want to piss off all the surgeons that did the study with them. So of course they have to say that they're all talented. So I'm not really sure how objective that statement is. Not that I'm not saying it's not true, I'm just saying it's not objective. So in conclusion, they tell us that they have really made a big step forward in this information for us, and that we should all stop doing vaginal cuff closure and keep doing laparoscopic cuff closures. So, I mean, maybe it's speaking to the choir here because all three of us do this already, but what do you guys think about that kind of statement after this paper?
I think they clearly outline why that's not a good idea. And the way they do that is that they do an effective review of the limitations of the study. And some of the highlights for me were that there is a very low incidence of obesity in Italy. And here we are practicing in the great United States of America, and we have an obesity epidemic. And so I think that our patient populations are very different, and to extrapolate their data to our population is a difficult sell right now. That being the first thing. The second thing is that, once again, we think that they have a very expert group of surgeons participating in this study who are doing a very standardized vaginal cuff closure technique. And I think that's a very expert level technique. And to apply that to a general group of surgeons who aren't used to doing that technique with a vicryl stitch, with a laparoscopic closure, with intracorporeal knot tying, I think is very difficult because there is a significant learning curve associated with that. And so I think those things were highlights for me as far as why we can't necessarily, generalize this to everyone.
I agree. I mean, I believe their data. It was surprising to me, but I believe their data. I don't know how generalizable it is to our patient population and also to our surgeons, gynecologic surgeons, because not everyone's going to be able to suture laparoscopically and continuously and tie intracorporeally in the way they do it. So they may show that the dehiscence is lower with laparoscopic closure, but I just don't know if it's going to be rolled out in practice here.
Yeah, I think I pretty much agree with both of you. I would say what I took away from this is if you are good at suturing the cuff laparoscopically, that's probably better for your patient. If you are not good at doing that, then closing it vaginally, even though maybe in this paper it shows that maybe it's not as good as a good person doing it laparoscopically, it is inevitably better than a bad person doing it laparoscopically. Right? So if you're not skilled at doing that, then close it vaginally if that's what your skill set is. But if you know how to do it laparoscopically, then you should do it laparoscopically. That's kind of what I took away from it.
I think, we've nitpicked a little bit about this paper, but what I found exciting about it, even just seeing that it was published, was that it's a randomized control study on a topic that has really a foundation in retrospective literature here. And I think seeing that this group was tackling it in a randomized control perspective way was really awesome. And I think what else was really nice to see is that this is the same group who for years has produced a lot of that retrospective literature. And, their curiosity remains, and their passion for really finding the right way to treat patients is is still there and they're still going after this research. It is really awesome from an academic standpoint.
I couldn't agree more. I mean, I have actually zero problems with this study. I think the study was gutsy to take on a project as big as this and have the resources and the people and the commitment to do it. I think is amazing. My quibbles are with how the paper was written and some of the things that they included and didn't include. But the actual study, I have nothing but respect for.
Yeah, I'm very impressed. I mean, they were able to do the study and enroll over 1,300 patients, and it's pretty impressive.
Yeah. I didn't actually look if they told us what time period they did that over.
They did. They started recruiting in February of 2015, and recruitment was completed in May of 2017. Right, so just over 2 years, yeah.
Right. Well, that's very impressive for that number of
It's a high volume. Yeah.
All right, so I think this was definitely worthwhile of a paper for them to do, for the publish, and I'm glad that we had the opportunity to talk about it. I hope that people out there who do laparoscopic hysterectomies can incorporate some of these thoughts into how they approach their surgery. I allude to the person who taught me, and one of the things that he taught me is that in order to be a surgeon with a capital S, one had to always question how you do your surgery. Every time you do it, you should be asking yourself, can I do this differently? Can I do this better? Is there another way of tackling this way instead of just doing it the way I was taught? And in doing that, you are always improving yourself because you are thinking about the fundamentals of that surgery and the anatomy and whatever new techniques come out. And so this is very much in that vein, that philosophy. And so I was very happy to read it. And I was also very happy to have the two of you on to discuss it. So thank you both for taking time out of your day to spend some time going over this paper with me.
Thank you for having us.
Yes, thank you very much. This was very exciting.
Okay. Well, then thank you again. And I look forward to having you guys back on the next time we have a fun topic to discuss. Thank you very much.
Thank you.
Thank you.